Hey folks, this is Eric with FlightBridgeED and welcome back. I'd like to take a few minutes and just recognize everybody for the support. We have had this site up for approximately 2 weeks now. We're up to 300, close to 300 friends on Facebook, and we're up to 140 followers on Twitter. I just want to thank everybody so much from the bottom of our hearts for supporting us, getting involved, registering for a forums account. We also have all of the podcasts now published on iTunes, so we're real excited about that. You can go on iTunes and search it under podcasts and search Flight Bridge, and you'll find all of our podcasts listed, and I believe you can actually register or put your email in and it'll send you alerts and download the new podcast to your phone when the new podcasts are uploaded every Monday night. Today I wanted to do our podcast on trauma management, and I wanted to emphasize fluid resuscitation and permissive hypotension. I think this is an extremely important topic, something that research has shown we in the past have not approached in the right way, and so I want to really emphasize that. So we're going to go through and we're going to start with a patient scenario. We're going to talk about hypovolemic shock. We're going to talk about the different fluids involved in fluid resuscitation. I might briefly talk about blood products, although this isn't going to really be a podcast on blood products, and kind of just go through the management of the fluid resuscitation and permissive hypotension. So we'll get started, and our scenario is a 55-year-old male patient that was driving a forklift. He was driving it on a logging road, and he got close to the shoulder. The forklift rolled over, ejected him out of the cab, and rolled over the top of his chest and abdomen. EMS was called. They arrived approximately 10 minutes after the injury. Patient was alert and oriented ×4, GCS of 15. He does have a visible crush, bruising, ecchymosis injury to the chest and abdomen. No head injury noted. He does have shallow tachypnic respirations. He has a crepitus over his chest and diminished lung sounds bilaterally, although there was no indication of a tension pneumothorax by EMS. The LZ was approximately 12 minutes from the scene. We're going to kind of emphasize this as far as a helicopter scene flight, and you arrive on scene, you land, you're waiting for EMS. So I'll refer back to this scenario on multiple occasions. We'll kind of talk about the management, and we'll kind of see how this goes. So let's ask a few questions before we start. So what problems can you see in this patient? How may his hemodynamic status change for you throughout your patient interaction with them? And what fluids are you going to use? And how are you going to manage his fluid resuscitation? How have we done that in the past, and how should we approach that now? And what things can we do that may cause further harm to this patient? In a lot of trauma management, in a lot of ways we treat trauma patients, our care can directly impact the patient negatively if we do things incorrectly. And it's not like we're meaning to do that. It's just based on new science. We're finding that we were way too aggressive with our fluid management. We were way too aggressive with trying to get a blood pressure up to the physiologic norm. We need to approach that in a different way. So when I lay out these podcasts, first I want to say is I try to do things off industry standard, whether it's EMS or HIMSS, but a lot of the approach and a lot of the things that I'm passionate about now is more research-based topics, things that have been proven through research. It may not be a standard or a protocol that's throughout the nation yet, but this is, what's being done in the primary, largest, most aggressive trauma centers in the United States and around the world. So, the whole point of FlightBridgeED is to reach people in all aspects, whether you're a doctor, nurse, medic, PA, or nurse practitioner, and just get you to think outside the box. Maybe try to treat your patients a little bit differently, or think about things a little bit differently. And I'm trying to reach everybody. And I, like I said, if you read the bio or the About FlightBridge on our webpage, you'll see that I'm really passionate about reaching people in rural facilities, rural EMS agencies, small areas that don't really get the same aspects of these level 1 trauma centers, these research hospitals, and they don't get that information, or it takes 5 to 10 years to have that trickle down. So the whole emphasis on FlightBridge and a lot of these podcasts are to try to get that information out there. All right, so with this patient, we have to obviously manage his airway. We need to make sure we have a good patent airway, and we're going to constantly look at that. And the other thing with this is we have to really be careful is he's got diminished bilateral lung sounds, and that can deteriorate really quickly. If he had a large forklift rollover on him, you know that's a lot of weight. That's a massive piece of equipment. So we need to kind of think about internal injuries, what organs maybe were affected, if he's got a spleen lac, a liver lac, does he have a bowel perforation, things like that. So we're going to kind of stop there on the scenario. Let's start talking about treatment of hypovolemic shock. So the first thing we obviously need to do, if we have visible bleeding, we need to stop the bleeding in whatever way we can, whether it's tourniquets, which tourniquets are a big thing now. Obviously the military, whenever there's a war, research is increased, and we learn a lot from military, especially right now with the Iraq War and Afghanistan conflicts taking place. Tourniquets are being used a lot because of the IED injuries, the blast injuries that are being seen over there. So tourniquets are a big thing. Obviously, we can go BLS and we can do direct pressure. We can put raise the extremity if we can, and do that. But obviously, in this setting, we need to get a patient to definitive care. We need to get them to a definitive trauma surgeon. And that's, if we go back to our podcast on the Platinum 10, that's where kind of that Platinum 10 comes in. We have to manage our patients quickly on scene, try to do as much as you can in the helicopter or in the ambulance, and get them to that definitive facility. Do all your procedures in the helicopter or in the ambulance. And so that Platinum 10 is really important. So let's talk a little bit about fluids. Obviously, the two main fluids we use in EMS pre-hospitally are going to be normal saline and LR. And when we give fluids to a patient, the standard has always been 3-to-1. So we're going to give 3 liters of fluid for every liter of blood loss, or we're going to try to estimate blood loss. And so 3 liters to 1 liter of blood loss. But the thing to remember is 333 cc's of that 1 liter, or that 1,000 cc's, is only going to reach the intravascular space. The rest of it's going to be dispersed in the interstitial space and things like that. So what the patient's going to see intravascularly is only going to be 333 cc's. And it's actually, the new research is showing that it's actually more of a 4-to-1 concentration, where you're only going to get 250 cc's that reaches the vascular space. So, we're given a lot of fluids, but really what's getting to the patient that's going to help them? The rest of it's going to hurt them. So we're going to talk kind of about that here going forward. Let's talk about the makeup of normal saline. I think in the past I never really thought about, previous to flying in HEMS the last 10 years, I really never thought about fluid choice. Obviously we were taught you could go normal saline and LR, and in a trauma situation you can go 1-to-1. But there's a lot to be said about that, and the fluids are very different. And so let's talk about normal saline. Normal saline has been kind of the standard for years. It was always the standard in blood transfusions because, that was protocol driven, and you could only hang blood with normal saline. That's changing throughout the country, where that's not really the standard. It has been, it's done all over the place where LR is used for hanging blood. The problem with normal saline is it's a very acidotic fluid, and the pH in normal saline is 6.0, I believe. And so a lot of times if you give a massive amount of normal saline, you're going to get what's called a hyperkalemic acidosis. So how we see this, if you look at your lab results and you look at your sodium and your chloride, you're going to have an elevated chloride level. And when we look at our sodium and chloride level, we should have a ratio of about 38. So what I mean by that, if you have a sodium of 140, we need to have a chloride of around 102, and that's normal. So that's normal. So in a hyperkalemic acidosis, you're going to have a normal sodium level, but your chloride may be 110 or 112. And so what that means is we have too many acids. Remember, sodium and chloride are strong acids. And then we also have albumin. So we have to realize that if we have an acidosis and we look at a blood gas, that's accounting for a big part of that acidosis is that increased chloride. So normal saline in large amounts is going to cause an acidosis, or it can make acidosis worse. So if you're giving masses of normal saline in let's say a sepsis patient, where we give anywhere from 5 to 10 liters a day, and they're already in a severe metabolic acidosis, that can obviously make things worse. So the sodium level of normal saline, I believe, is like 154, and the chloride level of normal saline is 154. So you can see that our normal sodium level is 135 to, I believe, 140, 145 range, and your chloride level is 95 to 100, 102, somewhere around there. And forgive me if I'm not exactly right on those numbers, but I know I am close. So you can see that your sodium, and especially your chloride, is excessively higher than our physiologic norm that we have in our body. If you compare that to lactated ringers is a very stable fluid. It's more of a buffer fluid, I guess you would say, and the pH for LR is around 6.7, so it's significantly higher, normal saline. Your sodium level for that is 130, which is real close to our physiologic norm, and our chloride level is 109, so it's very close to what we have and what we need. The problem with the LR is obviously it's got a lactate added to it, and I think it's like 28 milliequivalents per liter, somewhere around there. So if you had somebody that was in a severe metabolic acidosis, they had an increased lactate level, tissue hypoxia, or that you're seeing based on anaerobic metabolism, you're going to get you're adding to that. You're adding more lactate. And lactated ringers, you just don't want excessive amounts of that. So, in that situation, you're probably going to alternate. So which fluid is better for our patients? I think in a trauma situation, LR is probably going to be better. You don't want to add to the acidosis. You don't want to add to any problems. You're not going to, I guess, be faulted for doing a 1-to-1 concentration, doing one normal saline to one every LR, because you're going to see as I lay this out, we're not going to want to be given a lot of fluids. And that's where we're going to kind of get into the permissive hypotension and the management of that. Again, based on the military, we learn a lot about fluid replacement, trauma management after any war. And a lot of this theory, although that it's been around for a while, there's been some research in the last 10, 12 years, military really drives this home. And so the big thing now is massive transfusion with whole blood. Obviously, in the civilian setting, we can't do whole blood. And what they do in the military is they have all these soldiers walking around. They've got ID tags or dog tags. They have their blood type on there. And if they get these soldiers that come in that need massive transfusions, they'll just pull people right off the street there, have them come in, sit down, and drain some blood out, and they'll reinfuse that same fresh whole blood back into that soldier. Obviously, in civilian life, we can't do that. That's not possible. So we have the blood banks and things like that, and that blood isn't as good. It's been sitting around the blood banks for a while, and so we can't go exactly based on what the military does. We can learn a lot from their strategies and their treatment, but we can't mirror what they do. So let's talk a little bit about, I'm going to give you kind of two scenarios here. And we're going to talk about hemoglobin. We're going to talk about how our body compensates. So let's imagine we got two brothers, and one brother is stabbed, and he's immediately transported by EMS to a level 1 trauma center. He gets immediate treatment, and they draw some labs, and they get a hemoglobin level. And his hemoglobin level is 15. He's lost, let's say, 3 liters of blood, and so his hemoglobin level is 15, which we know is normal. Okay, we have the second brother, and he's stabbed also, but he's left in a back alley, and he has access to EMS and to the level 1 trauma centers about an hour long. When they get him to the hospital, he hasn't had any fluids at all, and they check his hemoglobin, and it's 6, and he's lost the same amount of blood. Let's say he's lost 3 liters. So why is that? Your body's going to auto-resuscitate. The body's going to pull fluids from the interstitial space, the intravascular space, and attempt to auto-resuscitate. So when we think about resuscitation, we really need to think about resuscitating all 3 compartments. We've got to resuscitate the intravascular space and the intracellular space. And as you can see, trauma patients can become very behind on their volume. So again, what's the correct treatment? Well, blood products is the correct treatment. Blood, whole blood, or packed red blood cells, plasma, and cryo. That's the kind of the cocktail nowadays. So how does that apply to us in the field? Well, I'm really a believer in understanding what's going to happen in treatments after we drop our patients off. And I think we need to always think about that, help them out. It's important that we manage our patients so the caregivers that take care of our patients after us don't have an uphill battle. So again, studies have shown that not aggressively resuscitating people in penetrating torso or chest trauma is the best approach. And you can also, I think, argue that same approach with blunt trauma. In blunt trauma, obviously, we have splenic ruptures, liver lax, perforated bowels. We have major bleeding that's going on abdominally in the chest cavity. And so I think we can use that same philosophy. So let's talk about penetrating trauma, or we'll just lump everything together. So imagine a Coke bottle. Okay, you have the Coke bottle that's half empty. We've dumped out half of it, and you put the top back on. There's some air in it, and you squeeze that bottle. And what's going to happen? That those contents are going to actually fill to the top of the bottle. And that's what we're doing, obviously, when we increase somebody's blood pressure. We're increasing the squeeze. Well, what happens? Our body obviously has clotting mechanisms and things like that to attempt to stop the bleeding. So our body attempts to stop the bleeding. And if we increase the pressure, we're going to obviously break loose that clot. That's counterproductive. We don't want to do that. So our goal is, again, number one, to get them to definitive facility. So let's take this a little further. So if we go back to our past studies or our past approach of fluid resuscitation, where we're going to give all this fluid, we're going to try to get this blood pressure extremely high, or I shouldn't say extremely high, back to a physiologic norm, 120s, systolic, etc. What are we doing to our patients? Why is that a bad thing? Well, remember, our blood contains other components other than hemoglobin, and obviously hemoglobin is essential to oxygen carrying and tissue oxygenation. If we don't have enough hemoglobin, we don't oxygenate our tissues. And obviously, normal saline and LR, they have no oxygen carrying capacity to them. So that's one negative thing. If our patient's bleeding out and we're filling them full of fluids, we're losing that oxygen carrying capacity. But hemoglobin is not the only thing the blood contains. It contains clotting factors and other important aspects of our clotting mechanisms. And so this is where we see DIC. And DIC is a horrible way to die. It obviously something that we a lot of times cause, not like we're meaning to cause that, but it's because we're not managing our patients appropriately. And I don't say that in a negative way. I say that like we've learned, based on research, we've learned medicine's always evolving, and the way we approached our patient care 10, 20 years ago is not how we approach it now. We've learned that giving massive amounts of fluid resuscitation leads to this problem. We're washing out all those clotting factors. And the same goes with massive transfusion. If you're giving 6, 8, 10 liters of packed red blood cells, you're also, that's where you need to start giving our platelets and things like that, because you're not getting the clotting factors that you need. So what does this all mean? Well, how can we manage our patients and achieve better patient outcomes? That's the whole goal, right? The number one thing we need to do is we need to adequately oxygenate our tissues. That's our number one goal. And if you listen back to my cellular respiration podcast, you'll understand I'm real passionate about this. That's all we got to do. We don't need to get our blood pressure at 120 systolic, 130 systolic, 140 systolic. We need to get our blood pressure to a point where we oxygenate our tissues, and that we don't bust open a clot, right? We allow the body to try to start healing itself. We have the auto-resuscitation, like I explained, with the fluids where everything's shunting and moving around. So how do we do this? Well, one of the things that I want to try to steer people away from, especially, medics in the field, we don't need to be taking blood pressures. Blood pressures in a trauma situation are going to lead you astray. And blood pressures can be off, especially with these automated blood pressure cuffs that we have now. They need to calibrate. Sometimes they'll give you false highs or false lows and things like that. If you put a manual blood pressure cuff on and you pump it up once and you're trying to listen for a blood pressure, and you can't hear it, and you let that back down and you try to attempt to do another blood pressure, your systolic blood pressure reading could be 20 to 30 points off just based on that, because you've made that artery spasm. So blood pressures in a trauma situation need to be tossed out. We don't need those. We have pulses we can check. We can check our radial pulses. We can check our femoral and our carotid pulses and get a good idea where we're at systolic blood pressure wise. So I really want to steer people, try to be checking pulses. Don't even reach for a blood pressure. There's no need to do that. We need to be worrying about other things. And I think the other thing is if you concentrate on blood pressure, we often lose sight of the potential problems associated with excessive fluid resuscitation. And often BP can, again, lead you the wrong way. If you're so worried about blood pressure, you're going to be trying to just automatically, we've been taught to fluid resuscitate and get that blood pressure up. And I'll give you an example. If you look at a blood pressure of 86 over 52, for most of us, that is, that's a low blood pressure. And I know probably as a new paramedic for me, I would have been a little bit nervous about that. I would have treated that aggressively to get that blood pressure up. But if you actually do the calculation and we think about what that means, that gives you a MAP pressure of 60, 64-ish around there. And that's all we need. Remember, we need a MAP pressure of 60 to 65 to perfuse our brain. And what I mean by that is we have to have a cerebral perfusion pressure of 70, right? And we have to basically, our cerebral perfusion pressure, how to calculate that is our MAP pressure plus our ICP. And obviously we don't have a ICP monitor in place or things like that, but we know a normal ICP is anywhere from 5 to 15. So you just add that to your MAP pressure, and that gives you what your cerebral perfusion pressure is. So blood pressure of 86 over 50, or somewhere around there, is going to give you a MAP pressure that's adequate. And I think if you can look back and be humble, I definitely will admit that I probably would have treated that blood pressure a little bit aggressively, and we don't need to do that. And that's where we got to change our approach. We've got to think about, what are we doing? Are we perfusing our brain at this point? Are we oxygenating our tissues, right? And I think you could argue we are. Science has proven that a MAP of 60 to 65 does that. So how can we optimize? If we're only going to have a MAP blood pressure of 60 to 65, and that blood pressure is anywhere in the 80 systolic range, and that gives you good tissue oxygenation and perfusion to our brain and our kidneys, how can we optimize that? Well, there's a few things we can do. Let's talk about giving some medications, and obviously the number one thing we can do is airway management. On severe sick trauma patients, airway management is essential. If we go back to this patient in the scenario where he's got massive chest and crush injuries and things like that, he, even though maybe maintaining his own airway and his GCS is 15 and things like that, is he effectively oxygenating himself having the massive chest trauma? Is he going to deteriorate in flight where you're going to have to decompress him or do a chest tube or even a pericardiocentesis? And it's going to be much easier to manage him with an airway that's secured via ET tube. So in that situation, RSI for him is absolutely indicated. Be aggressive with that. Think ahead of the game. Don't get caught with your pants down and have him start crashing and then have his airway be compromised, because obviously if he starts becoming hypoxic because of a tension pneumothorax or pericardiocentesis, his airway is going to be compromised as well. So let's maintain that airway, secure that airway, number one. So that's the first thing we can optimize. And we're going to put him on the ventilator. We're going to optimize oxygenation. Remember in the ventilator podcast series how I talk about, I know a lot of flight crew members worry that, well, I can't check compliance. I can't feel what's going on. And remember, in the flight industry, when you have your patients, trauma patients, we have them covered with a blanket. We can't assess them the same way. We can't listen to lung sounds the same way. So it's very difficult to reassess a potential pneumothorax. Is it moving to a tension pneumothorax? Well, the only way you're going to really tell that's 100% definitive is by putting him on a ventilator and maintaining and monitoring that plateau pressure. And remember, you can do that by doing an inspiratory hold. It's a half-second inspiratory hold on the LTV 1200s. If you're using the Revell vent, it's there's a manual button at the bottom of the ventilator, and you can hold that down, and it'll do a plateau pressure as well. So that's very important to do, and you can really trend and see what your patient's doing, because that plateau pressure is telling you what's happening pressure-wise at the alveolar level. All right, so that's very important. So we're optimizing oxygenation. We're maintaining that airway. Airway's number one. Well, what else can we do? Well, one of the things with trauma patients, when they're bleeding out like this and you're giving them fluid, obviously we're not going to withhold fluids. We're going to give them some fluids. I'm not advocating that we're going to just not give them any fluids. We're going to give them enough fluids to maintain a MAP pressure of 60 to 65. That's what we're doing. If that means that's a liter, then that's what that means. If that's 2 liters, then that's what that means. But we need to be stopping at that point. The other thing is we have to remember is your blood you're losing all this blood, and we're losing calcium, right? And so calcium is essential for the clotting cascade. Yeah, it's important for inotropy, and it has massive effects on vasoconstriction. So if we're diluting out our calcium, if we're losing blood, we're diluting it out with rapid transfusion, large bolus resuscitation efforts, we're losing our calcium. We're losing those intrinsic things that calcium does. So using an amp of calcium chloride or an amp of calcium gluconate is going to be an excellent thing for your patient. It's not going to hurt your patient. It's actually going to be a good thing. And so which one do we use? We got calcium chloride, we got calcium gluconate. Well, remember, calcium chloride is a more concentrated form. It can extravagate into your IV very easily, obviously, if you have no IV, and it's going to cause tissue necrosis. So with calcium chloride, I would say use that if you have a very, very critical situation, very sick patient, you need something to work right now. Obviously, it's probably better to use it in a central line or something like that. Obviously, in EMS, we don't usually carry calcium chloride. We carry calcium gluconate, and it's not as concentrated. So for 1 amp of calcium chloride, we need to use 3 amps of calcium gluconate, and that's kind of the ratio. So calcium chloride in this situation, giving an amp or 2 of calcium gluconate or calcium chloride. If you are in a facility, obviously ER, you probably would have access to calcium chloride. But in the EMS and HEMS realm, calcium gluconate is going to be your medication of choice. And giving an amp or 2 of that over 10 minutes is going to be excellent for your patient. It's going to replenish to help with the clotting cascade. It's going to deter that DIC. We're already trying to deter that DIC with more modest fluid resuscitation. Get that clotting cascade, a little bit charged with this calcium, and it's obviously going to help with vasoconstriction. Let's try to, increase vasoconstriction so we can increase preload, and that's going to translate to increased afterload. And so we've got our calcium on board. Again, these may not be in your protocols. I just want you guys to think outside the box. I want you to think, if you're training officers listening to this, get this in your protocols. This is science. This is research. You can refer to this, Google this stuff. This is the current science, and this is very important. So we've talked about permissive hypotension. We've talked about how keeping a systolic blood pressure around 80 to 90 is often adequate, and that we don't need a systolic in the 120s, 130s, that's counterproductive, that we're trying to eliminate over fluid resuscitation. We're trying to eliminate all those aspects, those bad things involved in that management. So let's talk about a few things to consider with that, though. We need to always think about the age of our patient. We need to think about medical history and things like that. So why do we worry about that? Well, let's say you had a 15-year-old male patient, blunt trauma, you arrive on scene. How is he going to be compensating? Well, he's going to be compensating by, he's going to be tachycardic. He's going to have all these catecholamines. He's going to really be fighting. And, he's got that young heart and young vessels and things like that. So he's going to compensate for a long time. And he's going to give you a MAP pressure with probably little ease or a little bit of fluid resuscitation. I mean, he's really going to do well for you, and he's not going to look maybe as sick as he really is. And so how can we tell that? Well, you're always going to, again, you're not going to worry about a blood pressure. You're going to look at pulses, and you're going to feel for a radial pulse. And if you don't have a radial pulse, you're going to feel for a femoral pulse. And again, you know how we'll go down the line and we'll check for a carotid pulse. But we're going to always start with a radial pulse, and we're going to feel their extremities, and we're going to feel how warm they are. And if they're warm in the extremities and their hands are warm and they've got good cap refill and they've got a good radial pulse, then you know that map pressure is actually a true map pressure. They're actually perfusing to the point where they're getting good extremity perfusion, and their capillary beds are filled with good oxygen-rich blood. If you take that same patient, blunt trauma, same injuries, but you have a 55-year-old male patient and he's got an extensive hypertension history and some cardiac history, again, you're gonna look at their extremities. You're gonna feel for a radial pulse, and if that radial pulse is present but their extremities are cold, then you know that they've got some pretty massive vasoconstriction because of their artery disease. And so if they're getting a map pressure of 65, it's probably not a true map pressure of 65. And so that's where we need to maybe be a little bit more aggressive. I'm not advocating going up to a map a map of 80, 90, but you need to look at your patient. You need to look at their hypoxic status, look at their SATs, look at their end-tidal CO2. Why did I say end-tidal CO2? Well, remember, end-tidal CO2 will give you a gauge on ventilation, right? It tells you what's going on ventilation-wise. What's their, what are they blowing off? The bigger aspect of end-tidal CO2 is it tells you hemodynamic status. It tells you about cardiac output. And that's all based on the Fick principle. It tells you what's going on oxygenation-wise, and cardiac output drives that. If we look at AHA guidelines, that's why they advocate using end-tidal CO2, is because you can tell a lot. If you're doing an arrest and you're compressing the chest and you have an end-tidal CO2 and you're getting a reading of 10, and all of a sudden, based on AHA guidelines, we don't check pulses anymore. We don't stop compressions to check pulses or things like that. The first thing you're going to notice when you have a return of spontaneous circulation is an increase in end-tidal CO2, and you would go from a 10 to a 30. You know that you have a return of spontaneous circulation. You have a pulse with that. It's a better indication for cardiac output and hemodynamic status than anything. So end-tidal CO2 is a must in these situations with your intubated patients. It's going to tell you a whole lot. So we got to look at the whole picture. We got to look at maintain their airway. We've got to look at their oxygenation status, and we've got to look at their map pressure. Think about their medical history. And I know there's a lot involved in this. For you ground medics that may say, well, I only have 20, 30 minutes with our patients, you can make a difference in this. If we dump 4 or 5 liters of fluid and we're really trying to maintain a pressure that really, what are we doing? We're washing everything out. We're washing their clotting factors out. We're washing all that calcium out. We're really doing a disservice to our patients. Some of the studies have advocated where we don't want a fluid bolus or fluid resuscitate whatsoever, that the first thing a trauma patient should get would be blood products in the OR. And you may see in the future that may be the trend, or it may be where we use strictly hypertonic solutions like 3% normal saline and things like that, because it's a better volume expander, and we don't need as much volume, and that's what they're using in the military. The medics on the ground in Afghanistan and in Iraq, they don't carry 5 or 6 liters of fluid. They carry 1 bag of hypertonic solution, whether it's Dextran or 3% normal saline, or I think there's some other ones that they carry. So just remember that we need to manage our patients for their clinical course. Paramedics, we're trained to treat now and not worry about what's happening later. We're trained to look at the small picture. What are we doing now? And I think when you get into critical care medicine and you get into the flight realm, and you nurses, if you're listening, you understand what I'm saying. You're taught to look at a care plan, or to formulate a care plan, and look at clinical course and look at what's going to potentially change this clinical course and your treatments. And I think we need to be thinking about that. We need to treat our patients in that way, and we can make a big difference. Leading cause of death in trauma patients is not the injury, it's our treatment, whether we're aggressive with our fluid management, whether it's rhabdomyolysis from muscle breakdown, and we're not aggressive with our fluid there. That's one instance where they need a lot of fluids, but that's going to be in the hospital realm, where they're going to have to give them a lot of fluids. They're going to have to alkalize their urine by giving them sodium bicarb, and try to really give them Lasix and try to get that fluid off so they don't go into chronic renal failure, or acute and chronic renal failure, and die from that. So if we go back to our patient scenario, we think about the potential problems with this patient, and we kind of revisit these questions. So what are the problems can you see with this patient? Well, obviously we have lung injury. We've got chest trauma, so we have rib fractures. We've got a pneumothorax. So those can definitely move to a tension pneumothorax. So we have that possibility. Hemodynamic status, well, he definitely could become hypotensive. And so we need to think about his age. We need to think about his medical history. We need to think about where we want to keep that MAP pressure and how is he perfusing. Look at his skin color. Feel his extremities and see if his fingertips are cold with a radial pulse or whatever. If he doesn't have a radial pulse, does he have a femoral pulse? Or are his legs cold? And how are we going to manage his fluid replacement? Well, remember, we're going to try to maintain tissue perfusion. We've got him intubated. We already designated that. We're gonna really optimize that with good ventilator management techniques, and we're gonna give just as much fluid replacement as needed to perfuse him and keep him at pressure in the 60-65 range. We don't want to cause further harm. We don't want to overload him. We want to try to keep that. Some strategies have even argued that we may in the future, where I said 80 to 90 on systolic, it may be 60 on systolic. That's where we may end up being, and it kind of goes back to what I said as far as putting our patient into a definitive facility and getting him to OR, and that's the first thing that they get is blood products, that they haven't got any fluid in the field. So let's just recap real quick as far as we talked about our hypovolemic shock. We talked about the definitive care, and that surgery is probably the number one thing. We talked about the platinum 10 and the importance of getting off scene quickly, whether you're in an ambulance or you're in a helicopter, that we need to be treating en route. We talked about the ratios as far as how much our patient truly gets intravascularly versus how much we give, and so it's thought to be 250 cc's for every liter that we give actually gets to the vascular space. We talked about the differences between normal saline and LR, and choosing the right fluid. For normal saline is going to be an acidotic fluid. It could cause that hyperkalemic acidosis, and LR is probably going to be more stable. So in a trauma situation, I'd probably steer more for LR, and in a sepsis situation or massive fluid replacement, whether it's DKA or anaphylaxis, distributive shocks like that, you're probably going to go a 1-to-1 ratio, but you need to be looking at those things. If we look at hemoglobin and we look at that hemoglobin of 15, and your treatment was immediate, well, we haven't had any auto resuscitation, where the second twin had an hour left before they got any definitive treatment, and their hemoglobin is 6, and it's because they've auto resuscitated. The body has pulled fluids from everywhere, and now your concentration is less because now we have more fluids and to hemoglobin. So that's why your hemoglobin level is lower. It's because your body's auto-resuscitated. And then we talked about the use of calcium and maybe kind of going that direction, giving an amp of calcium, and why that is, and the importance of the clotting cascade. We talked about the differences of calcium chloride versus calcium gluconate. And then we talked about looking at your patient overall, looking at the age and the vasoconstriction, and are you getting a true MAP pressure 65 based on what you're seeing. So I want to thank you for joining me, and if you have any ideas for a new podcast or anything like that, I'd love to have them. This again is for you guys. I'm going to continue to try to put out podcasts in the critical care realm based on FPC CFRN topics. And I want to thank you again, and keep following us on Facebook and Twitter, and we'll talk to you soon.